I give you today my third talk in 2 days, and I'm happy that still people are here. That's nice for me, and I hope you enjoy. I will focus on the first trimester screening for preeclampsia, why and how. And when we are looking on first trimester, we are thinking about the three cornerstones of first trimester first trimester. This is, of course, nowadays the NIPD test or first trimester screening for nodal translucency. We have an early anomaly scan. You see, yesterday I showed you some video clips how to do first trimester fetal echocardiography, so you can evaluate the whole fetus in the first trimester. And of course, we have the third column, the third cornerstone, the preeclampsia screening in first trimester. So is preeclampsia a rare condition? Not really. And when you look through the numbers, you see you have a basic prevalence of a preeclampsia of about 2 to 5%. But again, these are numbers from Great Britain and anywhere else. So I tried again to look for literature dealing with Latin America to see whether the numbers are much different here. And here I have a meta-analysis about preeclampsia in Latin America in a very actual publication. And what you see here is that you have a very high variety depending on the country you're in. It varies from 2% in Argentina and Mexico with 12%. But you can see a study in Argentina in the early 2000s may be different today, depending on other changes in society. And also the study in Mexico is from 2008. There's the questions where we still have these numbers, or maybe we are even higher today. But this is where you are, between 2 and 12% in Latin America. So it's quite a very important thing. And when we are looking on Colombia, I digged in deep in the numbers. Hypertensive pregnancy disorders account for about 60% of all severe maternal morbidity. And it's the most important hypertensive pregnancy disorder, preeclampsia. So it's very, very, very important. So I found another study from 2020 here from Colombia, where they just looked up the pregnancies with preeclampsia and compared them to normal pregnancies and look what are the reasons for preeclampsia. So of course there are many studies having done that, but this is something from Colombia, so I thought it's worth presenting. And they had various parameters, and I'm just showing on these pictures the relevant ones, which were statistical significant. And so there are, of course, the parameters you would expect. So when you see the preeclampsia group and the control group, of course, the median age was different. In the control group, they were a little bit later in gestation during delivery. I think that's what we expect. And the age, of course, beyond 20, below 20 years, beyond 34 weeks, years of age, it's more common in the preeclampsia group. And you see also the body mass index is significantly higher in the preeclampsia groups, things you would expect. Of course, weight gain is different. You have more patients with low weight gain in the preeclampsia group. And you see also difference in maternal age. Of course, women expecting her first child have an increased risk. So that's basically where it is like everywhere in the world. So there's really no difference. So when we look now a little bit differently on our three cornerstones, then we have to weigh it a little bit differently. And that's our point in my home country, that everybody's talking about NIPD and nobody's talking about preeclampsia. Preeclampsia is only an issue when my patient's coming up and said, I have a sister, I have a friend, they were suffering from severe preeclampsia, and I haven't thought about that it's so severe with early delivery, and nobody counseled her for that. And I think that maybe everywhere in the world, people are talking about NAPD, but not about preeclampsia. So it's worthwhile talking about preeclampsia is a condition with a disbalance of the triad of mother, placenta, and fetus. You know that the link is that the impaired development of the vessels here in the placenta lead to issues ending up in preeclampsia. I will be here on the pathophysiology side a little bit fast going through this slide. So we have an early phase, a late phase, and you see here the factors who are very important, and you know they are important, especially the placental growth factor, which plays a big role in diagnosis. So how we define preeclampsia, there is early onset preeclampsia, late onset, preterm, term pregnancy preeclampsia, and of course, everybody is concerned about the early onset preeclampsia. And these are the factors like in Latin America. This was a huge study in worldwide from the FIGO from 2019, but basically you find the same information here. So what are PE influencing factors? The history of the mother, of course, and then we have the uterine artery. Yesterday there were already a talk about preeclampsia, so you know the values and the blood flow. And there are PAP-A and PLGF as biochemical markers influencing the risk for the woman to developing a PE. So that are the basic studies who were dealing with uterine arteries. You know, of course, in the first trimester we have notching in all the uterine arteries, so this is not a factor we can deal or judge about. So when you work with uterine arteries in the first trimester, you always talk about pulsatility index, so and not about notching or anything else. So we have normal values since well over a decade, and you can figure out that the resistance and the pulsatility index are going down during the pregnancy. That means you have lower resistance here. And what is different to uterine artery blood flow? So you have seen pictures, but basically I want to tell you about how to measure uterine arteries. And it's completely different to second trimester. In the first trimester, you have a sagittal plane of the cervix, and then you move right and left. And with this parallel shift, you're very low in the cervix region and can display the uterine arteries there. It's quite different to a second trimester approach where you go up and more lateral to just depict the blood flow. And for me, basically, in the beginning, it was rather difficult to find these arteries in a good quality. And to be honest, it's still today sometimes. So it's time consuming, of course, but then you can display blood flows like that. You know that famous notching, and you measure the PI, and you do it on both sides, of course, because we need information from both uterine arteries, especially because of the laterality of the placenta. So there may be big difference. And in the final analyzing, we always count for the median PI and don't evaluate just one side. You see here the difference in the left and the right side. So important for us is always the median of both, and then we have normal values for that. So that was about uterine arteries in short. And then the PAP-A was very early on the market because we also used HCG and PAP-A for the first trimester screening. So it's obviously they tried to see whether it has a value, and it has. You see early preeclampsia patients have significant lower PAP-A values, so you can use that. But the better marker is PLGF. It's more significant. It is also lower in early preeclampsia. And so they were developing a competing risk model. And you see, for example, when you have here PLGF is a marker and you choose a cutoff of 170, that means a false positive of 10%, you end up with a detection rate of 72%. When you combine PAP-A and PLGF in the same false positive rate ratio, then you will detect just 2% more. That means PAP-A is a marker itself. It has some value, but when you have PLGF in addition, you can avoid measuring PAP-A at all. So I'm coming to back that later. So, and also what was done in that early time is about, is there a prediction for small for gestational age? Babies, neonates, and it is, but the detection rates are much smaller and lower because of the influence of other markers dealing with low birth weight. So there it doesn't work as well. So at that point, I was asking myself always, yeah, so what? Now I know somebody is at risk, what I can do against that or for that. And you know that already in 2009, there were a meta-analysis which find out that ASA is useful if applied before 16 weeks. So the older colleagues in the room, and I count myself to this group, know what we have done 30 years ago with aspirin. At that time, we measured blood flow in the uterine arteries in the 22nd week of gestation and applied aspirin when there was an increased PI or notching. And end of the story was we skipped that because there was no benefit. The problem was it was just too late. The placenta didn't benefit anymore, and you have to apply it before 16 weeks of gestation. And so there were more studies, and they saw that when you apply aspirin before 16 weeks of gestation, you can reduce the risk for early preeclampsia by about half, and it doesn't work beyond 16 weeks of gestation. And normal preeclampsia, there was no significant difference. And it was dose dependent. There are studies between 50 and 150 milligram, and you see there is a dose dependency. That was the basis for the big study from London, from Nicolaides, the ASPIR trial, where they applied first trimester preeclampsia screening on every patient, and the patient with the increased risk were randomized for getting ASA 150 milligrams or not. And this study was then published in 2017, and to my opinion, as a very good conducted study, this was the game changer in our field. I think this was a very good performed studies. They were very proud about this adherence of 80%. 80% of the patients in the study actually did what they told to do. This is very good for studies. So in many studies, patients are not concurred to the protocol. And what they found out here was very, very interesting, that when you have a risk selection by preeclampsia screening in the first trimester, and you apply ASA in the high-risk group, you can reduce early preeclampsia by a factor of 5 to 20%. And even it works in preeclampsia below 37 weeks, that was new. Even there, we have a reduction of 60%. But in the later pregnancy, preeclampsia cases beyond 37 weeks, there are other influence factors which are not influenced by ASA. So that's what we all know. I would like you to remember this slide, because this graphic is that what I'm telling my patients all the day. When you are a patient, you have a very severe, you would have a very severe preeclampsia with early delivery at 28 weeks, you are benefiting the most. So it will be, the delivery will be delayed by 8 weeks. And we don't have to discuss about the difference between 28 and 36 weeks for the baby. But less severe preeclampsias are, the benefit is less, of course. So you see how the gap is getting smaller. And of course, this is academic here, but there are cases delivering so late. But you see, when you about 37 weeks, the benefit is statistically at about 5 weeks. It will be beyond delivery, but maybe even that will be a benefit. But you see that that the value is very good in the very severe cases, and it's getting less in the higher pregnancies. I like this graph a lot, and I show it to my patients all the time. So now another point. Do we need the screening? It's not for free. And depending on the area where other people cannot afford it, the people who need it most can't afford it. And there is a study from 2019, they call it the return of the triple test. All people like me know what that was. For trisomy 21 screening in the 80s, you had taken other blood, drawing blood, and had a very bad test in quality-wise. So they call the triple test, you have the maternal blood pressure, the uterine PI, and PLGF. And do I need everything to evaluate the patient? And they just did an analysis, and what they figured out is that you don't need blood tests, uterine Doppler, basically, if you do a two-stage approach. And this is very cost effective. It's all about money. So when you are doing the maternal history, and it's a normal history, then you don't have to apply any other test. So, but when the history is abnormal, then you have to go further on and go for more tests. Depends on your resources. So when it's difficult for you to draw blood about PLGF, then this may be a way, or you are not qualified for uterine arteries. So, and the other way is when you are qualified for uterine artery Doppler, but it's problem that the people don't want to pay for the blood analysis for PLGF, you can do just the uterine arteries and the history, and then you have only a third, 35% of patients who need more further analysis. And on the other way, when you're not qualified for ultrasound, but you have blood results, you need just 25% of the patients, and you have to go further on. So it's cost effective, and that may be a way to go when you want to apply this, but funding or the patient's charge just cannot afford it. I think the two slides are interesting, a little bit, maybe new. So finally, I have a case report. 37-year-old gravida one, 30 weeks of gestation, and BMI of 39, obese, hypertension, primary hypertension, normal cell-free DNA test, like they have in Germany. And she was referred for first trimester anomaly scan, and I was counseling the patient. So what you would think about? Of course, we went for a preeclampsia screening test. So we had all the numbers, and we put it all together, and we come out with a increased risk. We did PLGF, and we had a risk for preeclampsia of 1 in 24. This is below 1 in 100. So we gave her ASA, aspirin, 150 milligrams. So that's pretty standard. So the recommendation always is ASA at bedtime. You know that. Why? So I looked into that. It's basically that patients with preeclampsia risk tend to have an hypertension, like this woman. It's very common combination. And ASA influences in a positive way the blood pressure in the hours after applying ASAs. That means when you give it at bedtime, you have a blood pressure reduction slightly during the night, which is very nice because that's the area where you normally have no control. So this is the point why you give it, you apply it at bedside. I always like when I can explain things to the patient when they ask me, because some do. So that was a study who looked about that. But going back to this case report, there was already one point in the beginning I was not referencing about. So you saw the BMI of 39. Do I need a preeclampsia screening at all? That may be the question. In Germany, we have guidelines for obesity and pregnancy. And there are certain recommendations. They are backed up by literature, of course, like recommendation in obese patients to do a preeclampsia screening. But we have one recommendation that people over and BMI over 35 should have ASA right away without preeclampsia screening. That's the only point. It's an evidence level grade 4 statement. But that means we call it GOGSAT medicine. You know that, good old guys sitting around the table. That means experts are, talking about, is it good? Yeah, that's very good. We should do that. Scientific value is a little bit impaired in that. So, but still in our country, there's discussion about that we should give patients ASA, which is rather cheap, right away when they have a BMI over 35. So I haven't found Colombian numbers here. The German numbers, we have at least 5 to 6% patients over 35 BMI in the range where you're getting pregnant. That means about 5% of all our pregnant women would get ASA right away. This is just a matter of discussion. So finally, I would conclude for you. Preeclampsia is very common. It can be very severe, and preeclampsia screening is one of our cornerstones in early care. You can avoid things you won't have. It's one of the rare conditions where you can avoid something. Trisomy 21, you tell a diagnosis and you have no really solution. Cardiac malformation, you have not really a solution. But here you have a solution. This makes it very applicable. The patients are going with that. They love that. You can think about a 2-stage screening for cost reduction. Depends on your population. You can think about whether you give your patient ASA right away when they are beyond 35 in the BMI. And when you apply ASA, you have a reduction of preeclampsia by 80%. This is great. And finally, again, delay of preeclampsia up to 8 weeks by ASA means this is very important information for the patient. Thank you very much.